Good afternoon, everyone. Thank you very much for joining us today for this session. This is an interesting session. I've been looking forward to it myself. I'd like to take this opportunity to appreciate each one and every one of you for making time and being able to be with us today to learn about this important project that we've had for the last 1 year. My name is Rukia Abdul Kadir. I'm a holder of MPH, that's Masters in Public Health, and also an executive director. I'm in Kenya. I also work with Kenya Red Cross, Emergency Plus Medical Services, which is an emergency wing of Kenya Red Cross as a quality manager. Today, I'm very happy to host this session. I think for the purpose of allowing people to know who they're interacting with, I'll put on my video. Welcome all, Happy New Year. I think the purpose we have today in this session is to understand the lessons from Midwives, maternal ultrasound screening project that, as I've mentioned, was running for the last 1 year. We'll have a brief background later after I've managed to introduce each and every one on our list of panels. We have 10 panelists to begin with. The first panelist is Miss Margot Quidman. Margot is also a very good friend of mine. We're working with her on a project in Marsabit, and the Philips Foundation has been very supportive to me, particularly, and I really appreciate the effort in trying to make healthcare accessible to everybody. Welcome, Margot, and I'm happy to have you today. So Margot joined Royal Philips in December 2016 as the director of Philips Foundation. And she's a trained lawyer, very interestingly with a good background. And after being a company lawyer for the last 3 years, she was listed and published, listed in publishing company. So she started setting up her own businesses, and she's very good in the business department as well. So before joining Philips, she was an entrepreneur for the last 23 years with a good background in finance, marketing, and sales. So she built up marketing and wholesale company in food supplements and sold that once it had matured for the last, between 1997 and 2007. She also had a very good consultancy firm, provided boardroom advice regarding corporate social responsibility and sustainability, as well as societal aspect of supply chain. So for last 9 years while she was working for Philips, she's been the director of Philips Foundation, supporting most projects in actually globally, not just in Kenya. So she's been with us. Personally, I will attest that she's also working with me on a project like I've mentioned earlier in Marsabit County. And we have also with us Professor Joachim Osur, who's also from AMREF. Professor Joachim Osur is also a technical director at AMREF Health Africa. He's associate professor of sexual and reproductive health, and also the dean of School of Medical Sciences at AMREF International University. Welcome on board, Professor. We also have Nagis Kaka. Nagis has 13 years of experience as a nurse and 7 years as a compliance officer, in addition to coordinating maternal child health activities in Ministry of Health. As a national EMOC, that's Emergency Maternal Obstetric Care, trainer and a gazetted inspector by the Ministry of Health. Welcome on board, Kaka Nagis. With us, she's also an officer in Nursing Council of Kenya, responsible for standards and compliance. So that's a double role she has, both at Ministry of Health and also Nursing Council of Kenya. We have Miss Ruth Waiua, representing Ministry of Health as well, a holder of BSN and Master of Science in Nursing from the University of Nairobi and University of Dundee, respectively. Ruth also has a postgraduate diploma in sexual and reproductive health and rights from Lindsell University, Sweden, currently pursuing her PhD in midwifery. So we have very good backgrounds of our panels in maternal health as represented by our ladies. We have Ms. Priscilla Ngunju, who has been the coordinator of the project. Priscilla is a project coordinator for the Maternal, Newborn and Child Health MNCH project at Amref International University. In her role, she leads the implementation of this project that positively impact on the health of these mothers and our children. So she's a holder of a Bachelor of Science in Nursing and a Master's degree in Public Health, both from University of Nairobi. She's also an alumni of the previous Women in Leadership program from Strathmore Business School. Very impactful work, especially in women and children. So she's been also very passionate about the maternal and child health. And that explains why she's handling this particular project. We have Dr. Mika Matiangi. Dr. Mika is currently the Director of Open Distance and E-Learning at Amref International University, and also has been following closely and supporting Priscilla in the project achievement for the last 1 year. So Mika has 17 years experience in training human resource for health, with lots of interest in community maternal child health. So that also explains why they have designed this project, and they're actually monitoring its results. Mika has passion for development of innovative solutions in the area of MNCH, nursing and midwifery training. Has also implemented several health projects in Amref and is currently the principal investigator, especially on this particular project. We have Jackson Muri, who is also a sonographer and radiographer at Kenya National Hospital with over 8 years of experience, clinical experience, and very key for the team here who have been handling the project because he had supported them a lot with the training of the midwives. He possesses vast experience with an in-depth multimodality radiological procedures, knowledge, majorly ultrasound and magnetic resonance, imaging, radiology systems, and patient safety. So I think I've given a highlight on the panelists we have here today. So welcome on board, and I hope you're ready for our session. So I will also highlight why I'm actually particularly interested in this project, because I'm also very passionate about maternal health. As I've mentioned, we have a project that is running, also supported by foundation, which is basically designed to support MNCH community systems, community health systems at the grassroots level, especially in the rural setting. I cannot emphasize enough the need for such initiatives under the leadership of Dr. Mika, the foundation, and Priscilla as the project coordinator in running this very important activity. We actually appreciate the fact that ultrasounds are not very popular in the rural setting. In fact, it's something that has remained available in the urban setting more than in the rural setting. So bringing such services to the community and collaborating with existing community health system is actually very vital, and I acknowledge the need for such initiatives in the rural setting. So well done, Team Priscilla, Team Dr. Mika, and of course the foundation for supporting such a great initiative. So having said why I'm actually interested, then I will request that we go through the program of the day. Our program today we have started, we're already 15 minutes late, but I'll quickly take you through how we're going to flow today. We have introductory remarks by the moderator, which we have already done. We have opening remarks by our Vice Chancellor from the university, Amref University, Professor Marion Mutungi. We have our director, the Phillips Foundation, Ms. Mago, will also have an opening remark. We also have a quick presentation of the project background and video presentation as well at 2:30. Hopefully we may be running a little bit behind schedule, but we'll keep up with the requirement of our timing. Presentation of lesson learned from the pilot project, We also have opportunities for issues that need to be tackled by the panelists that we have on board today to be able to share their experience as well as also respond to the queries that will have come in and the questions that will have been asked. We will give opportunity to the participants. We have 76 participants. That's impressive. Thank you very much for joining us. We will have questions, room for allowing you to ask questions. And I will request that the question and answers be directed to the question and answer button. I will track that as we continue with the presentations. And of course, as the panelists respond to the issues that they will have been given to respond to. Thereafter, I think we'll have an open forum to see if there is any queries, is there any questions from the participants, from the panelists, a more live interaction, if time allows us to do so. For that opportunity will be given before I make my closing remarks. So I will give an opportunity to Professor Marion Mutugi to take us, to give us her opening remarks. Welcome, Professor Marion Mutugi, and thank you very much for joining us today.
Thank you. And just to say, I'm not Marion, Professor Sur here, representing the Vice Chancellor, Professor Marion Mutugi, and also the AMREF Group CEO, Dr. Gidinji Gitahi. Both of them were to be in this meeting, but because of other activities going on in AMREF and in the university, they are unable to attend. And so they both sent me to talk on their behalf. And so on behalf of them, and also on behalf of AMREF Health Africa and AMREF International University, I want to say welcome to the meeting. We appreciate the collaboration and achievements of this project, and we thank you all who have been involved. We hope this marks the beginning of a very exciting engagement rather than the end, because the results of this pilot are only going to be beneficial if we scale them up. I would like to say that primary healthcare setting in which this project was implemented is where AMREF Health Africa really has a lot of experience. It is also where AMREF International University is doing its research and extension. And so we know a lot about primary healthcare, and we know that it is in the primary health setting where 80% of Kenyans actually receive health services. We therefore need to improve primary healthcare and make all services available at that level. Because when we do that, we will then make available these services to the bigger majority of Kenyans than when they are only available in higher level referral health facilities. In fact, it is the problem of lack of comprehensive services at primary healthcare level that makes the country have the health indicators that we have right now. If we want to change those health indicators, then we must find a way of improving health services where the majority of Kenyans access healthcare. And so putting more resources in primary healthcare, improving services in primary healthcare, making services like imaging services available at that level is the most important thing that we can do in improving health indicators. And you know, if ultrasound services can only be accessed in higher level facilities, it means people have to travel. So transport becomes an issue. It means they have to use money, which they would have used for food, to access imaging services. And so by introducing some of these services at that level, it may appear something very simple, but we are impacting families in a very big way. But this noble idea or project will not succeed unless some things are put in place. The first thing is that our regulators must embrace the concept of task sharing. So I'm talking about the medical council, the nursing council, all the regulators. We know this has been a problem. There's a lot of push and pull between the professions, which only benefits individuals and not the majority of people who need services. So if we can all embrace task sharing, a lot more people will benefit from health services and we will save lives. And so for this project to succeed, the task sharing agenda must be embraced by all regulators and all partners working in this area. This project has proven that what actually WHO and UNFPA has said for a long time, that if you train a midwife well, 87% of perinatal services can be offered at a very low level. They can do it. And so regulators, I think we have evidence and let's appreciate that. But the second thing is that this project can only succeed if our county governments support it. So far, we've gotten a very good support. We thank you, Kpis, Kajiado, and other counties that have been involved. We appreciate this collaboration and we hope that this support will continue so that in future, even after this pilot, we are able to scale up ultrasound services by midwives. So the support, because health is devolved of the county government, is very important. The third reason why it will succeed or not is how we strengthen our public-private sector engagements. And this also includes engagement with academia, because we have to generate evidence to show that it works. And so we thank Philips Foundation, and we hope that this pilot will be scaled up and you will give more support even to other counties. And as AMREF and AMREF International University, we will be ready to support and we know the counties will appreciate. So those three things become very important and I hope we can embrace them. I would also want to say that despite COVID and many other problems that we are currently facing as a country, UHC agenda has not been dropped. We need to ensure that UHC succeeds, and this is an important way of contextualizing interventions. If we can contextualize interventions and have some of the African needs met through projects as this, because we know in Africa, we will not be able to provide ultrasound services as in developed countries, then we can achieve quality UHC through such initiatives. I know time is up. I will not say much more than that. And just to thank everyone for attending this call, and also all our partners for the money, the time, and the effort we have put to make this succeed. Thank you very much.
Thank you, Professor, for that well-defined and long, interesting highlight on the scene. I have probably a quick input to the same, just to critically emphasize the importance of what you have just said. As you all know that we have several factors have affected access to these critical services. We understand that ultrasounds are accessible, as you have said, in the urban setting, at also the cost that is prohibitive for most of the people who live in the rural setting. So availing such kind of services at an affordable rate and where it is actually critically needed, and it's very, very key. And I think for me personally, even in my own county, as an add-on to what we're already doing, I will feel that this is areas that we can actually collaborate on. So thank you very much, Professor. I will give opportunity to our next panel member also. She's Dr. Miss Mago Kuiban. Feel free to have a few words.
Asante Rukia, and thank you, Professor Osur. My name is Margot Kooijmans. I'm the Executive Director of the Philips Foundation, which is a not-for-profit entity funded by Royal Philips, the global healthcare technology company. And the Philips Foundation's mission is to provide access to quality healthcare for populations that lack access to medical services. Thus contributing, of course, to SDG number 3 mainly. And as you announced, my background is in business, and I have always sought to work on the, let's say, the cutting edge between the private sector and society. I believe we're in this together, and we are all one. Now, the Philips Foundation can issue grants, and we can provide diagnostic equipment and services, deploying the capacities and the skilled volunteers of the Philips company, and that makes us what we can be for, and how we can serve society. However, we want to explore and help develop sustainable, scalable models, improving access to quality healthcare, but then creating lasting access, which rarely is achieved by just donating, and that we experience a lot. We have identified ultrasound pregnancy screening as one of the areas where we can do this, and where we can try to explore together how we can reach those sustainable models. And as we know, the World Health Organization recommends 1 ultrasound scan before 24 weeks gestation. Obstetric ultrasound helps estimate the gestational age and supports the prediction and management of possible complications during pregnancy, labor, and birth. However, we also know that in rural and remote areas of low resource settings, diagnostic imaging is often insufficient or completely lacking, like Professor Osur was also addressing. The availability of compact, portable, and digitally connected ultrasound devices opens new ways to improve access to diagnostics in remote areas. Therefore, in projects across the world, we are pioneering new delivery, referral, and income models with NGOs, governments, and social entrepreneurs. In a number of projects run in Kenya, we are educating midwives to deliver antenatal pregnancy screening in village clinics, while being supported through telehealth support by radiologists at distance. In a project with Aga Khan University, we will offer this service at primary care levels in 3 sub-counties of Kilifi, and assess the effects on aspects such as quality of service, uptake of early prenatal care, improved outcome of pregnancy, and communication between pregnant women and community health workers, all indicators of better maternal and child mortality outcomes eventually. In the project presented today with Amref International University, and also a separate one we do with Farm Access, we focus on testing and finding sustainable income models that could form the basis for scalable models from a local economic point of view, to enhance the living conditions of these communities. Furthermore, in Uganda, we have been working for quite some time on setting up educational programs to build ultrasound skills for remote health workers. And we are now working with NGOs, with the NGO Imaging the World, to set up a centralized training facility in Kampala. We will organize another webinar soon to discuss these programs in more depth, and we would invite all of you to be part of that. You will hear more about that soon. Yeah, I would leave it to this point, and thank you, and over to you, Rukia.
Thank you, Margot. I cannot emphasize more. The only solutions that we have at the moment must be sustainable. That is the end point to all this discussions that we've been having, because I think most projects have faced the atrocities and also the diminishing opportunities for further funding. Once the project is one of the projects that have been very, very key and very informative, very actually required by the society. Unfortunate situations happen that they're not going to be scaled because of lack of funding. So the approach you're taking, I think, is very valid. And I would like also to take this opportunity to additional participants who have joined us. Thank you very much again for taking your time to join us, and welcome on board. We are still in the program, the initial stages of the program. We have only had 2 of our participants and our panelists as well, having had the opportunity to give us the opening remarks. We are at the stage where now we will have a brief highlight from my end, then I can give opportunity to the respective persons to do the presentation. Just to give you a background of what this project was all about, and why, what it was based on for it to have come to birth. Ideally, all pregnant women should undergo, we all understand that they should undergo the obstetric ultrasound, as Margot had, Professor had highlighted earlier. We have this project that began in December 2019. AMREF and Philip Foundation initiated that project. It was a 1-year pilot project in Kpis and Kajiado counties, focusing on 10 pilot sites within those 2 counties. To date, they were able to have screened mothers in the 1-year period that they have executed the project. 1,107 women benefited from that. Across the 11 months that they have been in operation, 3 months were actually set aside for mentorship, and of course, identifying the midwives. Once they identified, they had them fully trained with the support of the radiologist, and of course, meeting the prerequisite requirements, which required that they conform to standards. They work with the ministry and the National Council, Nursing Council of Kenya, and the radiographers also had an opportunity to give their blessings to the project. So we will have more insight and more discussion around that once they have had an opportunity to make presentation on this. Their target and their overarching goal was actually to sustainably improve maternal and perinatal care of women in underserved community through strengthening point of care, personalized and responsive midwifery services. I think you all understand the importance of having an ultrasound scan for a pregnant woman as soon as you're in your 24th week of gestation. That is what the WHO recommends for all of us. And this is basically just to be able to identify or capture early enough any anomalies, any issues with that pregnancy, so that the mother can be given the appropriate advice in good time and be able to be monitored throughout a pregnancy thereafter. So we cannot emphasize more than this the importance of these ultrasound services at the grassroots. And the challenge mainly we have, apart from missing this service, is also coupled with the experienced cadres and experienced persons to actually provide this important service at the grassroots. So their project strategic objectives were to optimize the quality of maternal care at primary healthcare level in developing country context, the build capacity of unemployed midwives. This is also creation of opportunity for something for the midwives to be able to earn from the project, as well as continue servicing, giving these important services to the community. And this was basically in targeted areas of maternal child health to enable them provide entrepreneur and personalized care to mothers in underserved setting. We also have to test the role of point of care midwives, led ultrasonography, screening services in mitigation of pregnancy related risks. So this will have been a very important target, especially when the midwives have had the opportunity to learn and also execute the same activity, and for that opportunity to be scaled up to many areas that will require the same services. And the lessons learned from this will be very vital in terms of sharing the experiences, and the lessons and the difficulties and the challenges that they will have experienced in the course of executing the project. We also have to develop a scalable, cost-effective and sustainable public-private partnership model, increasing women's access to essential ultrasonography. Remember, Margot mentioned that this had to be a sustainable model, and that is what they have been trying to, as a strategy going forward. That is their focus as the foundation, and basically it's just to ensure that you're able to work on your own after they have given you the capacity, the input, and also the requirement to be running the projects as you had put in your concepts. We have the expected outcomes from the project. Basically, it was to improve livelihoods among the involved frontline health workers, the midwives. And in some setting, of course, you will realize that there is the requirement that community health workers be their backbone in terms of continuing with the promotional activities, health promotion activities, the home visits, and the alerting them, of course, on when there are issues that they may have identified in the course of their home visits, and they work hand in hand to ensure that these projects have realized its goals. The other outcome that was expected was improved women's access to essential and personalized maternal and newborn care. We also have institutionalization of essentials of ultrasonography, training in Kenya, tertiary colleges, and developed healthcare units. And this is what Professor was highlighting. And of course, now they have the opportunity to train. They have a university. This will be a very good avenue for them to strengthen in future. We have proof of business case submitted on sustainable implementation of basic ultrasound screening in primary healthcare setting led by the frontline workforce. So that's the outcome. We have more of this in the presentation, which we'll be moving to in a short while. So we will be having the project background and video presentation. I will request that the video presentation to take, I think, to be take effect immediately.
The ultrasound screening project for midwives is a partnership among AMREF International University, Philips Foundation, and Philips. We're working together with the county governments of Kpis and Kajiado, as well as the Nursing Council of Kenya and the Society of Radiographers. We are doing a pilot study in these two counties to see how sustainable it would be if a midwife conducted a screening for a mom during her pregnancy.
I joined the midwife ultrasound screening in November last year, 2019, and I've really benefited with the project. We were trained using the Philips Luminify probe.
We have been able to see the increase of mothers in our facilities. Also, we have been able to screen the mothers, and we have been able to detect some of the abnormalities in our mothers. Like for one, we did one mother and two mothers. We were able to screen for twin pregnancy. Then there are two mothers also still we are able to screen, and we are able to detect IUFD. And we are able to screen two mothers who were imagining that they were expectant and they were not.
As a midwife, I really expanded my knowledge because now I can screen by my own, and I can detect the abnormalities and refer when necessary. And also I'm able, instead of palpating, I'm able to see the presentation, the lie, and the fetal heart of a fetus.
We engaged county sonographers in Kpis and Kajiado counties to train our midwives. They then trickled down what they learned to serving our mothers, therefore providing quality screening during their pregnancies. So far, we have managed to screen about over 1,600 mothers since November 2019 to date. This has been beneficial to our mothers as it is an affordable service and it is available at their local facilities. Mothers are able to pay for it because it's cost effective and it's available for mothers whenever they go to the facilities.
Another extra benefit to me, I've really gotten an extra earning from the screening.
We hope that we'll be able to scale up this project to other counties within Kenya.
excellent video. And Priscilla, well done. From this point, we will be doing our lessons learned from the pilot project. Kindly, the presentation will be done by Dr. Mika Matiangi.
Good afternoon, everyone. Is my screen visible?
Yes, it's visible. You can put it on the slideshow.
Is that okay?
Yes, that's fine from my end. And I can see some participants are also commenting that they are visualizing it well.
Okay, thanks everyone. I welcome you to this session to share the experiences from the Midwives Ultrasound project. I'll be brief as much as possible because I can see time is really dashing ahead of us. Thank you to the partners, thank you the stakeholders, thank you the participants, and thank you the counties of Kpis and Kajiado, which have been hosting the project. Already a lot has been said about the background of the project. So I will not dwell so much into that, but in this presentation, I'll more dwell on the intervention approach, the results, the challenges and lessons learned, and maybe recommendations before we get into the discussion led by the moderator. But allow me, give a quick sneak peek on the context on which this project was started. As you are all aware, in sub-Saharan Africa, most of the mothers, they carry a pregnancy for 9 months without knowing exactly what they're carrying. Yet WHO expects that they should have one ultrasound scan before 24 weeks gestation. And even the International Federation of Gynecology and Obstetrics also expects pregnant women to have at least 2 ultrasound scans during pregnancy. Now, what is very interesting is that we have only 25% of pregnant women in Kenya accessing an ultrasound during pregnancy, which tells you the majority, 75%, they don't have access to any ultrasound scan to fulfill this expectation from the WHO and even our own government or MOH policies. How can we achieve this? Yet within our settings, we have only or less than 1,000 sonographers who are meant to serve about 10,000 health facilities in Kenya. That sounds very difficult to achieve, and that's why this project was incepted. Of course, our moderator has taken you through the objectives of the project, that this project was geared to strengthening the quality of antenatal care in primary care settings. Why PHC settings? Because this is where we have limited access to most of the diagnostic services and even most of the primordial preventive care interventions within our developing countries. I don't want to labor so much on the specific objectives because the moderator has already pointed out what they were before the project was initiated. Allow me say something about the intervention approach before we share the results and the lessons learned. In this project, we trained 42 midwives from the 2 pilot counties using standardized content, and the standardized content was delivered using a blended e-learning modules, which participants were able to cover for 2 weeks. And of course, also we had 10 sonographers also went through the same content as well, as we prepared for a 1-week face-to-face training after having gone through the e-learning modules, which were provided by one of the partners, that is the Philips. Then after the training, we grouped 2 to 5 midwives into 1 business unit. And this is basically to ensure that even if one of them is away because of sickness or One of them is on a straight shift. We love somebody at least who is giving the service within the facility that was piloting. Of course, also we inducted the professional sonographers into this project so that they know how to mentor and coach the midwives who were supposed to give the services from the 10 pilot sites. And already we have one of the sonographers in the panel, that is Mr. Jackson Muli, who was one of the key drivers in the training of the midwives and also mentoring them and coaching them for the 3 months before they started working more or less autonomously with less remote support from the sonographers. Of course, again, to test the income model, we had to discuss with the counties which were piloting the project to allow us open a centralized pay bill number whereby the mothers were to pay the fee or the user fee for undergoing the screening. Of course, a baseline survey was done, and during the baseline survey is when we were able to identify how much mothers can pay for this service. And let me say at this point, most of the mothers were willing to charge a figure ranging between 500 Kenya shillings and 1,000 Kenya shillings. That is about $5 to 10 US dollars. But in the project, we opted to go for the lowest amount, that is the $5 US per screening session. And of course, let me mention that in the project design, again, we agreed to ensure that the midwives who are taking part in the project, they get an incentive, which was performance-based. That is, it's proportionate to the midwives that the number of mothers who have been screened by each of the project midwives. Allow me point out that this intervention is very much well within the ICM competencies framework, because some people were questioning whether are we doing things within the ICM midwives framework. Yes, if you look at Pillar 4, that is competencies specific to ongoing care of women and newborns, you can attest that within that pillar, midwives are supposed to be empowered to ensure that they can support not only breastfeeding, they can also detect complications which are occurring during pregnancy or during the prenatal period. And therefore, the midwives obstetric ultrasound project, it fits very well into that expectation of ICM, that by doing this screening during the pregnancy period, midwives are able to detect any of the complications likely to compromise the outcome of the pregnancy. Let me point out basically the pathway that the project followed, or the project took. It of course started with the stakeholder engagement, and that's working with the Nursing Council, with the Sonographers, Radiographer Society of Kenya, to ensure that all stakeholders are well aligned. And then of course, we had the county governments nominating midwives to be trained in the project. We had a very clear nomination criteria on who was to be nominated or selected rather for the training. And when they were selected, they were trained. After the training was done, we took about 3 months coaching and mentoring those midwives. And later I will mention that one of the lessons learned is that training midwives, coaching them and mentoring them is very key in the success of this project. And we appreciate the Radiographer Society for taking their time. During this mentorship and coaching period, we were not charging mothers. They were just being screened for free. And we had about 950 mothers, scanned without paying during the training period. But later on, when they started paying, the midwives were able to screen 1,250. That's up to December. The figure that was given by the moderator earlier did not include the data for December, which was a bit low, and I'll be giving reasons why as I present this. Of course, a lot of teamwork is needed for us to do scale up of this project, as we shall realize at the end of the presentation. Of course, in terms of establishing a business unit comprises of 5 midwives, and within that team of 5 midwives, you have one of them who is the team lead. The team lead is in charge of ensuring that each of the midwives is making use of the technology appropriately, is giving the service as per the standards which are set by the project, and of course is able to coordinate the business unit to ensure that there is no day mothers are coming to the facility to seek the service and they don't get it. And of course, the business units that we established, each of them was having government support, was having the technology supplied by one of the stakeholders, that is the Philips East Africa, and of course supported by the Philips Foundation. And Of course, again, to ensure that the business unit functions well, we were having the training of those giving the service, and also we train them on even business skills so that they know how to care for their clients, and also identify some of the enablers and barriers to succeeding in implementing the project. And again, I will say that each of the project was supported, each of the business unit rather, was having the support of a radiographer. So in case the midwives, especially in the first 2-3 months, in case they had challenges, they had a radiographer to give them support, to interpret whatever they were not able to do during the scanning of the mothers. Let me quickly take you through the results. That is post-training period. The midwives, of course, have said they have so far screened 1,250 ANC clients or pregnant women. And within this period, we have been able to do operational research study to check on the utilization or on the uptake of ultrasound, routine ultrasound screening services for pregnant women in the pilot sites. And of course, I should mention at this stage that the paper will be published next week in Open Clinical Diagnostics Journal. We'll be able to share the link with the stakeholders. But what we have heard is that there was an increase to 50% in terms of uptake of routine ultrasound screening. The baseline in the primary healthcare settings, there was no routine ultrasound screening service at all. It was, let me say, less than 10%. So we can see that because of this intervention of having frontline healthcare workers, and that is the midwives, doing the service, we were able to increase the uptake of the service up to 50%. And of course, distance to accessing, or the distance mothers covered to access the service, also reduced very significantly. In the baseline survey, we noted that most of the mothers were traveling distances of up to 30 kilometers to access an ultrasound. And you all know, those of you come from the rural areas, you know that mothers are only sent for an ultrasound in case a clinician is suspecting a complication. But because of this mobile technology that was deployed through the point of care ultrasound service delivery, that is the POCAS, we were able to reduce the distance that mothers were accessing ultrasound screening in the pilot sites to between 3 and 5 kilometers for 45% of the mothers who were assessed during the operational research. Also, allow me to point out that because of the project, we were able to have 21% of pregnant women going for routine ultrasound screening within 24 weeks gestation. But at the baseline survey, we didn't have this at all, because most of the mothers, they knew that they only do an ultrasound in case there is a suspected complication or upon referral by a clinician from a given point of service delivery. Allow me again, as part of the results, point out that we had a very interesting trend on the mothers who turned up for ultrasound screening. Of course, cumulatively, between January and December, we had 1,250 mothers who were screened. But allow me to point out that you see very unique features. In January, we screened 84 mothers, but in February, the midwives were able to screen 202 mothers. Now, in the month of March, when COVID came in, most of the mothers were very scared going for services in the health facilities. And the number of mothers screened in March dropped to 158. In the month of April, again, this when we're having the peak of COVID-19 in Kenya. And the same with the month of May. You know, the numbers were not so encouraging because of the COVID-19 risk, which was perceived to be very high by the mothers. And so they were not going for the services in the health facilities. And this trend continued on even up to September. But around October, you can see the numbers of mothers going to the facilities started increasing as the perceived risk or the risk perception was also reducing. And in the month of November, the number was quite high. In the month of December, the numbers were very low because of the industrial unrest. The nurses and midwives were on strike, so mothers were not coming to the facilities. But also, what was very interesting is that in the month of February, the numbers were very high because we did a community sensitization. Not so many mothers, let alone their partners, their male partners, are aware that ultrasound screening and a routine one is very important before 24 weeks gestation or by 24 weeks gestation. But when we did a sensitization just before the month of February and part of the first week of February, in both counties, the numbers increased. We did another sensitization just early November, last week of October, first week of November. And you can see the number of mothers who turned up increased. So one other thing that is very, very important is that we need to do more education of our pregnant women to appreciate the role of routine ultrasound screening. And this can be done using CHVs, among other community gatekeepers or community-owned resource persons. In other words, what I'm saying is, were it not for the COVID-19, by now we would have screened almost 3,000 mothers or more. But because of the pandemic, the numbers were quite highly compromised. In another study, which we shall be presenting later on to stakeholders, we did a study on the effect of COVID-19 on the maternal health outcomes and also on utilization of NC services. We shall be sharing these results with the stakeholders later on during the pandemic period. You will indeed appreciate that the COVID-19 affected utilization of NC services, among other services delivered within health facilities, very, very significantly. Of course, as part of lessons learned, let me point out this, that midwives are able to learn the essential ultrasound screening skills. It is very clear from the project that it is possible to train midwives and they will be able to deliver this service in primary healthcare settings. After all, they are the majority in the primary healthcare settings. Also, we have appreciated that mothers are very willing to pay for this essential service. We didn't see mothers expressing unwillingness to pay. In fact, they are willing to pay between $5 up to $10. And this informed our our sustainability modeling, whereby we're assuming that county governments will be free to charge this service, between $5 and $10, because as we know at the moment, in most of the facilities in Kenya, whereby ultrasound screening is being done, they charge around 2,000 Kenya shillings up to 2,500 Kenya shillings. In fact, some, they charge up to 3,000 Kenya shillings. That is around $30. So if we can offer a service which is below $10, it is quite affordable, and mothers have expressed, that willingness to pay for the service because it's very affordable or quite available. In fact, one of the experiences we had is that mothers were equating the cost of the ultrasound screening to the price of 1 kilo of meat in the rural areas. A kilo of meat actually goes for almost the same amount of money. So mothers are able to spare a kilo of meat to undergo an ultrasound screening. So sparing 2 kilos of meat for the sake of knowing their health status, that was not a big or will not be a big issue at all. Also, what you have learned is that the community sensitization is very crucial, is very vital. And of course, training, mentorship, and coaching of midwives is very important. And sustainability of the centralized frontline health workforce in terms of ultrasound screening, whereby the ultrasound screening is centered on frontline health workforce. It is something that is doable, it is sustainable, but it is subject to the volume of mothers who are turning up in the facilities. And we also observed that mothers were turning in higher volumes within public facilities compared to the private facilities. In other words, I'm saying if we have these services more domesticated within public facilities, we are likely to have a break-even achieved more earlier or more easily than when they're domesticated within privately owned facilities. Also, allow me point out a few other lessons learned as I come to the conclusion that women's education level, the pregnancy gestation, and the distance to the point of care were very critical determinants of undertaking obstetric ultrasound screening service. And therefore, this justifies why we need to ensure that the service is closely or is available within the household, within short distance of the households of the women, so that they can have more uptake, more utilization. And of course, technology that we are using here, it is mobile. One can travel, a midwife can travel with the technology and give the service far away from the service delivery point. I'll point out one example from Kpis County, a facility called Marani Health Center, whereby a midwife who is called Mary Grace was able to travel a distance of 20 to 30 kilometers to give services to clients who are booked on specific days waiting for her. And that's one advantage of point of care ultrasound screening services. The technology is quite mobile, and therefore the midwife can travel far from her facility of deployment and give the service to mothers who are being booked around the dispensaries or within dispensaries which supply mothers to the nearby health centers. Of course, again, some of the midwives were able to travel to the clients' households and give the service within their households without mothers having to travel to the health facility to receive the care or to receive the screening service. Of course, again, when mothers were being asked why they do the ultrasound screening, most of them, they do this service, or they seek this service rather, because they want to know the gestation of their pregnancy. They want to know the fetal position. They want to know the fetal sex. These were the main reasons which were bringing mothers to the facility. But in the process, of course, again, the complications were being identified very easily. Now, of course, midwives, ultrasound skills were satisfactory in terms of acquisition is another lesson we learned, because we had comparative rating of the skills by the sonographers and the midwives themselves. And only 3 parameters were statistically significant in terms of the rating, which basically didn't bother so much, because the 3 parameters which midwives were having challenges scanning was identifying the anatomy of the spine and identifying or analyzing the anatomy of the pelvis and the abdomen of the fetus. Also, we had a few challenges, midwives doing analysis of the fetal head and the face anatomy, which are not very worrying parameters. Otherwise, the most critical parameters, the midwives were able to display appropriate competencies in scanning them. The slide here is basically showing us the average ratings by the sonographers on the skills and the competence of the midwives who are involved in the project. And 5 being excellent and 1 being poor. You can see the sonographers or the radiographers, they rated most of the competencies at a range of 4.4 up to 5, which is basically bordering excellency in most of the parameters which the midwives were meant to scan or they were meant to analyze during the screening. The challenges which the project faced, of course, one of them was the COVID-19 pandemic, and of course that 6% drop of rate by the midwives whom we had trained, and most of them were to do with the relocating to other counties where they were being offered better terms in terms of employment. The other challenge we had was low male involvement in issues of women seeking ANC services, demotivated community health workers, and this affects creating demand for services in the primary healthcare settings. And of course, we had what I may call, undercurrents, in terms of inter-health professionals' alignment in task shifting. And this is why I want to echo the message from Professor Osur, that as a professional regulatory bodies, we need to look at what is it we can decentralize in terms of these critical services. What frameworks can we have in place to ensure that these services are available in the underserved settings to the marginalized communities or in the primary healthcare settings whereby mothers don't have much access to diagnostic services? Let me mention the last lesson learned, and this is economic sustainability. The modeling which has been done here, it is hinged on the least amount of money that mothers were able to pay, that is the $5. And also, it is also pegged to an assumption that we'll be able to screen about 20 mothers, within a month, a very low number, which basically can be surpassed very quickly within public health facilities. Now, using that assumption of screening 20 mothers within a month in a business unit and increasing the number of mothers being screened at 25% in each and every month, it could take about 8 years to break even, because the entire technology and the training of the midwives in each business unit was costing about 900,000 Kenya shillings. 900,000 Kenya shillings is almost $1 million. It will take about 8 years to break even if you cost at such a very low, costing, $5 for each of the service or each of the session of screening, and then screening 20 mothers within a month. It will take you about 8 years to break even. But you can concur with me that in most of our facilities, it's possible to screen even 100 mothers within a month. It's just that the COVID-19 affected the numbers we were screening each and every month. It is very possible to charge more than $5. So with all these kind of assumptions, is it very possible to even break even within 3 years or 4 years? That is, recover all the costs of acquiring the technology, training the midwife, deploying them, being mentored by the sonographer or by the radiographer until the service is well grounded. So what I'm saying here is I'm building optimism and assurance that it is very possible to acquire the technology, deploy it, and recover the costs within, let me say, within 3 to 4 years, especially for public facilities, whereby the volumes of mothers is quite high. Let me conclude by giving these recommendations that there is need to improve women's knowledge on benefits of ultrasound screening. There is a very huge gap. Our women do not appreciate this at all. We need to educate them, empower them, so that they go for this service. You know, when I look at the number of cases which midwives were able to see, of course, every pregnancy has a but there are those risks which can lead to a very adverse outcome of pregnancy. We had over 20 women referred or detected, you know, the outcome of the pregnancy. And this justifies why we need to have this service within the frontline health workforce. Of course, it is very possible to have a sustainable business model. From the pilot project, we have confirmed that it is very possible to have a sustainable business model, you know, by rolling out this intervention to more facilities, to a wider scope as well. And of course, let's have a policy framework to regulate this decentralization so that we have what is very clearly delineated for the frontline health workforce and what is delineated for those who are giving services in the higher levels of the health system. And finally, national and county governments, it is time to invest in this mobile technology. Let's invest in this mobile technology. Instead of using the conventional ultrasound machines, I'm not saying we don't have them or we don't buy them. Let's buy the conventional ultrasound machines, yes, that is fine. But for the sake of access on the advanced pregnancy outcome. Thank you much. Thank you for the back to the moderator. Thank you.
Thank you very much, Dr. Mika, for the brilliant presentation.
Rukia, are you there?
Yes, I'm there. Can you hear me? Can you hear me now?
Yes, you can proceed. Yeah, you are audible now. Thank you.
Yeah, okay, thank you. I think, sorry about that, the brief hitch in the internet connectivity. Thank you very much, Dr. Mika, for the brilliant presentation. So it's actually quite insightful. I can see some questions from the participants. I would like to request that we will allow some issues to be responded to by the panelists to be presented first, and then we can go to the question and answer session. I'll be able to share your questions to the panelists, and they will respond to your questions. So please keep on giving us your questions. I'll keep note of those. I think now we'll proceed to some of the issues that we will wish the panelists to respond in the interest of time. And Dr. Matiang'i, well done, you've kept your time, and we are actually as per our schedule. The first question is, will be to Professor Osur. Professor Osur, we have AMREF Health Africa and its subsidiary, that is the AMREF International University, which is a renowned organization in sustainable health development. What is the next after the pilot phase of the midwife, once the project phase is over? This goes to our professor, Professor Osur. Is Professor with us, or I can redirect the question back to Dr. Matiang'i and Priscilla?
It seems Professor Osur has left for another meeting that was to start at exactly 3 p.m. But I'll say this, and our project coordinator, Priscilla, you are free to augment this. Our next course of action as Amref Health Africa and Amref International University, we believe in scalability, or we believe in scalable projects, or we believe in scaling up pilot projects which are successful. And that's why we have the Nursing Council right from inception up to now. We wish to have standardized content for training midwives on doing obstetric ultrasounds. And we wish to have this intervention also scaled up to other counties, especially the 14 counties which are having poor MNCH indicators. Already our partner UNFPA has taken up 2 counties, whereby they have funded acquisition of the technology in Migori and Homa Bay counties. We want to believe that with time, we're going to get more traction here from other counties. And of course, an appeal to our partners that we continue harnessing and building more resource mobilization to ensure that the intervention is more accessible in other areas beyond the country, to other neighboring countries where we are having poor MNCH outcomes. Thank you.
Thank you very much, Dr. Mika. I can see you've also responded to one of the questions that have come in with regards to training of midwives on obstetric ultrasound. Priscilla, do you have anything to add on that, or we can move to some of the questions that the participants have asked directed to Dr. Mika in regard to the same?
No, Dr. Matiang'i has answered it quite well. We can move on.
Okay. Dr. Mika, there's one question here for you. That is, did you also investigate the outcome of the provided ultrasound services? That is, did you have more skilled attended deliveries or found potential pregnancy complications? Did you also investigate the outcome of the provided ultrasound service? That is, did you have more skilled attended deliveries or found potential pregnancy complications?
Yes, I pointed earlier that we had about 20 cases of mothers who were identified to be having what I may call high risk complications. There were mothers who had IUFDs. There were mothers who were having multiple pregnancies, of course, and they were not aware. There are mothers who also having low-lying placentas. There were mothers who were having fetus with poor cardiac activity. And these are part of the risks which were able to be mitigated because mothers were referred on time for more advanced care. But we were not able to, we didn't have the objective of knowing the effect of ultrasound screening on pregnancy outcomes. There is another project being done by Aga Khan University in Kilifi, and that is their main research question or research objective, which we shall get to know later on. I hope I've answered the question.
Yes, thank you, Dr. Mika. I think that was a question from Frank. Frank, if you feel there's something that requires more elaboration, then you can give us a shout out through the question and answer. We have another one to you, Dr. Mika. What is the main reason for the impressive uptake of the ultrasound screening? What are the key considerations? Is it the reduction of the distance? Does the cost of the screening weigh in? Were pregnant ladies interviewed to get an insight in the experience? That is also directed to you, Dr. Mika. Before I give an opportunity to other panelists to continue with the issues.
I hope I've got the question clearly. It's about what were the main drivers for the uptake of the ultrasound screening? Is that the question?
Correct. And what are the key considerations? Is it the reduction of the distance? Was it the cost issue? Or were the pregnant ladies interviewed to get an insight in their experience? He has actually given us a lead on the responses.
Thank you. I think it's multiple factors that are acting as drivers for the increased uptake. One of the drivers, of course, is the mobile or the point of care ultrasound screening, it reduces the distance that mothers travel to have the service. So mothers do not worry about getting transport, bus fare to pay, to go and access the service in a referral center. The service is within the community. So they can easily access it. They can even call the midwife to go to their house and give the service. So that's one of the critical factors which was driving the increased uptake. The other one is, of course, the cost, quite affordable. You know, a mother could come to the facility and say, I'll sell tomatoes for 2 days and I'll get money to pay for the service. Another one will tell you, I'll sell vegetables for 2 days, I'll come back and have the service. So the affordability is a critical drive as well. So in terms of interviewing the pregnant women, yes, they were interviewed. We have another set of qualitative data, which is being published separately for this project. And what mothers said is that the point of care ultrasound screening service has made it easy for them to know the status of their pregnancy on time without waiting until 9 months are over to be told that they are having a low-lying placenta or they are having complication A, B, so they need to undergo a cesarean section. We'll be sharing that as well in a separate publication for the qualitative data. Thank you.
Thank you, Dr. Mika. I would like to give this opportunity to Margot to respond to this issue. For participants, I would like to request that we have a few issues to tackle with the panelists, then thereafter we are able to respond to your questions. I have seen them trickling in. So Margot, kindly respond to this. This is one of the commendable innovations from Philips Foundation and Philips East Africa Limited to improve health of populations in the underserved setting. So what are the drivers? What drives development of the solutions and how do you ensure they're entrenched in the country's specific health systems? Dr. Margot, sorry, Ms. Margot.
Thank you, Rukia. Thanks for the question. I think development of solutions has to start from an identified need. It's not that we want to impose anything onto anyone. It has to start from a need. Like in this case, meeting the WHO recommendation for pregnancy screening and the fact that it's just not available in these regions. Now, Philips has promising technology to address this challenge, and we also know, and it was again addressed in this meeting, that reaching underserved communities is a major challenge. We want to bring the technology to underserved communities by developing new innovative models that address the, let's say, the different challenges in the last mile. And we see that this is an innovative approach to be on top of the explorations and not to be merely a donor, because we learn so much by what's happening on the ground. And of course, our funds are also limited. Our pockets are not that deep that we can continue funding endlessly in all countries, let alone all, not in all counties, but not in all countries. That is completely clear. So partnering with leading organizations like AMREF is essential to develop these models that could have the potential to be replicated at scale in a sustainable manner. And this includes financial sustainability. And we have learned a lot in this project. We need to adjust and increase awareness and increase the utilization grade of the equipment. And also policies are key. And we should do so knowing that proven and sound medical service provision models will be invested in by government and can also attract other funders to scale. Because that's what we are after, scale, sound models that really help provide quality healthcare to these communities. And the projects need to enable health system strengthening and change. And I'm pleased that the Radiology Society and the Nurses Council of Kenya and the county health teams were all so closely involved in this project. So this kind of work requires deep insight in the medical and local circumstances. yeah, we really deeply want to understand what creates the best way, the best models. And we need to know about the medical and cultural circumstances. It's co-creation, including the community sensitization that was being talked about. And finally, each county or country is unique, yes, but we should see things not in isolation. There's a lot that can be learned from successful initiatives in other countries. We are happy to share and also to learn from other pilots and explorations. And probably 80% is replicable, and the remaining 20% must be tailored to the local context. There's no need to repeat this 80% in additional pilots, and that's something I want to advocate for. They are expensive and small at scale, and we need the courage from everyone involved to take the successful pilot projects forward to the next level, present working models and scale to the benefit of the mothers and children, as well as the medical staff, and the accessibility of the prenatal screening that can avoid so many risks instead of only, let's say, act when the risks already occur. So happy to deepen the learnings from this pilot and see how we can, standardize a way of working that can be scalable. Thank you.
Thank you very much, Margot. That was quite extensive, and I think it's beneficial to also all participants here today to understand the model of operations of Philips Foundation. My second question goes to the panel, and I'll direct it to Dr. Matiang'i first. To the implementing partners, what are the challenges that you faced while implementing such projects? I know you've mentioned quite a number. If there's anything probably you want to highlight further, Dr. Matiang'i, you're free to respond to this issue.
Not at the moment, not more than what I shared in the presentation. Thank you.
Thank you, Dr. Mika. So we'll go to the next question. This will go to as a regulator for nurses, this will go to Ruth. I will direct this to Ruth and as well as Kaka Nagris, because they both have a background in the NCK. But to begin with, we can start with Kaka. As a regulator for nurses and midwives, what opportunities does this portend for pregnant women in primary healthcare settings? Nagris can respond, then you can be supported by Ruth.
Thank you very much. From a regulator point of view, we know we still have high maternal deaths in Kenya, like 362 in every 100,000 live births. That is KDHS 2014, and perinatal deaths of 22 per every 1,000 live births caused by preventive factors. So once we train the midwives on ultrasound, and the ultrasound done antenatally, that will go a long way in determining the complication that may inform the necessary care needed for the women, hence improving the mother and baby survival chances. We also know that most of the primary healthcare facilities also do provide maternity services based on the Ministry of Health guidelines. Maternity complications at times happen during labor, which inform the outcome of both mother and baby. So a midwife with the basic skills in ultrasonography could easily detect these complications and make an informed decision, which will improve both mother and baby outcomes. The other thing is access. Access to scanning services that would be made better, since the Lumify machines were portable, and the midwives would be able to even visit the clients to their doorstep, like Dr. Mika said. So that is another opportunity. Then also empowering the midwife means that the services will be feasible. For the client, it was going to as low as 500 shillings, which I think is quite affordable, but still we need to think about how to incorporate into other, maybe health insurances that deal with pregnancy, because even these 500 shillings, according to the midwives who are trained, some of the clients would not be able to afford. But basically, I also want to bring out something that midwives would also get hold and run with. I want to say that this is good for the midwife, for the part of entrepreneurship, because they could be able to do this and at least have something for themselves. So for the mom and baby, we know that we have multiple of advantages. We just need to look for where the opportunity is and run with it. Thank you very much.
Thank you very much, Nagis. Ruth, do you have anything you will wish to add on this?
Yeah, thank you for the opportunity. I want to concur with what Kaka has just said. I do agree with all those sentiments. Maybe some addition in terms of what opportunities does this pose to the midwives. Of course, we see professional career development for the midwives, or capacity building and strengthening the skills of midwives, of course, is something that is desirable for better outcomes of maternal and perinatal health outcomes. However, to achieve this, definitely we need enabling policy and environment and a safe legal framework for the midwifery practice. And that will actually enable better regulation for the same practitioners. And therefore, perhaps a recommendation that I would make on this would be establishment of a well-structured community midwifery policy and guidelines, as in we keep on talking about enhancing reach quality of care at the community level, and therefore establishment of a proper policy framework of the community midwifery practice would be one of something to think about. Of course, aligned to the Kenya Health Policy Framework, and also aligned to the reproductive health, the National Reproductive Health Policy. So such are some of the things to think about, and these will be informed at the higher level besides at the service at the back end and high level. Would be happy to get a cost and benefit analysis in terms of purchasing the same technology or machines at the county level, your countrywide. What does that then mean in terms of cost and benefit? Perhaps a further analysis of the findings in terms of deaths averted or lives saved or emergencies that were attended to that are attributable to the use of the ultrasound scan by the midwife could add value to such decisions. Thank you.
Thank you very much, Ms. Ruth. That was quite impressive. And Ms. Nagis Kaka as well. We wish to consider that, as we all know that the success of each project must have buy-ins from all key stakeholders who have a role in ensuring the success and the progression as well as scale up of such an important project. So I would like to request Jackson Moody that this will be directed to you. AMREF, Radiographer Society of Kenya, and Philip Foundation making with midwives sonographers. And there's a question again from the participants in regard to the same. Are there any regulatory issues in offering decentralized diagnostic services by ultrasonographers? So I would request you to kindly respond to that question.
Okay, thank you, Rukia. Hope you can hear me clearly.
Yes, we can.
Let me start by saying no to the question. Society of Radiographers, AMREF, Philips Foundation are not making midwife sonographers. For you to be a sonographer, like you have to go through an intense training. And what the aim of the project intends to do is to basically improve the point of care practice. When talk of the issue of point of care has been a topical subject, and it's been applied in variety of ways in different disciplines with different outcomes, not only in maternal and child health. And it's high time that we also embrace the same, bearing in mind that we have got quite acute shortage of trained professional sonographers, especially in developing countries like Kenya or low resource settings like where we exist. And I believe it's a timely opportunity. It's not a point of making the midwife a sonographer, but improving the quality of services. How we're looking at it from our point of view is we basically like empowering the midwife with an extra tool to triage the patient or the mother much better, in the sense that we're able to identify high risk pregnancy or high risk issues that might be of concern as far as the pregnancy is concerned. And to answer the question of regulatory issues, there are no involved regulatory issues. The only concern is if one intends to go and practice on their own, like set up a unit and say you want to practice, basically you'll have to go through the normal regulatory processes. But for point of care, it's different scenario in this case, because basically you're utilizing ultrasound to improve the quality of services. That's how we look at it in that perspective. Thank you, Rukia.
Thank you very much, Jackson. That was quite elaborative. Just to add on that as well, we have a challenge of the various cadres that are serving in the hospital setting, in the community health setting, especially the primary healthcare setting. We understand that these services and these cadres are actually, there's a huge shortage, I mean to say, in the rural settings. So it's actually key for the government, for this, as mentioned by Ruth and Nagis earlier, to collaborate on this effect and ensure that when such an opportunity arises, there is reinforcement and support and development of the various policies and regulations to keep up with the same. I would like to go to the next question, and this will be to Ms. Ruth again. The Ministry of Health oversees training nationally, which includes the county government's devolved units. What is the Ministry of Health's reaction to standardizing such a training for all midwives in Kenya? So kindly respond to that, Ms. Ruth.
Thank you for the opportunity regarding the reaction of the Ministry of Health in terms of standardizing the point of care for midwives. Definitely an approach, an intervention that helps us strengthen the capacity of the midwives at the point of care is again the right direction, trying to adjust the human resource needs in terms of the skills and the numbers, workload related matters. And therefore, working closely with the Nursing Council, who are involved in issues of regulating education alongside the consumers or the same health service providers, who is the Minister of Health, it's a step towards the right direction. With proper training plan, clear mentorship guide, supervision guides, and the thinking beyond the pilot setup, where my assumption is that the pilot setup could have been highly controlled. Of course, there were items of incentivizing the same midwives, and therefore, my thinking is if this is scaled up wider in an uncontrolled, the universe or the whole country where control is less, then we need to think about mitigation matters, mitigation measures of some of the challenges that perhaps were observed during the training. One of it being the technical itch that was presented as a small challenge that was observed, that some specific midwives were not able to maybe articulate some technical issues. So suggestions on mitigating that would be helpful. Perhaps maybe a longer duration of training, a continued mentorship and coaching, clearer supervision, or perhaps targeting slightly higher level of midwives, looking maybe at the postgraduate midwives also. I am not so sure exactly what posed the challenge of the technical each. And then the other things to consider is, again, why are we making midwives sonographers? Trying to follow on that is, again, were there challenges around the workload? The same midwives is supposed to do MBCD, and how are they able to incorporate that? So if some of those questions are answered, then of course, the Minister of Health will be impressed to improve the skills of the midwives and to improve point of care issues as a matter of trying to deal with the very unpalatable indicators of maternal newborn health. One of the other suggestions I'm thinking about is, again, integrating the same training in the life-saving skills, emergency obstetric and neonatal care training, which is a short course, a CPD course for the midwives, may help out picking the complications, as in we are aware that majority of the deaths and the complications occur around labor and delivery and immediately after delivery. That is the point that we terribly need interventions on, and the use of ultrasound may help out in navigating and exploring causes of some of the obstetric complications that need immediate attention. Again, thinking about, linking, referral and the linking of the complications observed. As in, I'm asking myself, when the midwives were able to identify these complications, were they able then to refer? So as in, again, looking at it in a slightly wider perspective, among how do we refer these, are we able to intervene or add value? So contextualizing the training within the emergency obstetric care package would be a step towards the right direction. So thank you so much. Thinking about sustainability would be helpful. A very beautiful project that Minister of Health would recommend for the midwives. Thank you.
Thank you very much, Ms. Ruth, for your response. And it was also quite elaborative. I think I'll be checking through the question and answer, and for any clarity or probably any question that will require attention, and redirect it back to you. We have, can be responded to by all, but I will initiate with the Philips Foundation. Margot, I can initiate, I can direct this question first to you. How do we ensure that the best practices that emerge from pilot projects, and to be more specific, the POCUS projects, are mainstreamed into national health policies? We can start with Margot, then we can pick up on Bruce, and then thereafter we can give opportunity to Nagris to also say a few words.
Thanks. I think that this starts, of course, with proof points, like we are trying to collect in this pilot, and we have collected some impressive proof points together in this collaboration, and I think this should show that the lives of these mothers and babies can be improved by implementing these kind of practices, including all of the circumstances that have been addressed, and also sensitization, training, technology, and so on. So then, in fact, there is no reason left not to change the policy, right? Involving all the stakeholders that can be inflicted by new policies, but that is something we together can start thinking about. What could that look like? Over to you.
Thank you very much, Margot. In the interest of time, I think I can allow Ruth to respond to this. Also, a quick highlight from your end, and then we can proceed to the next question.
Thank you. Again, I do concur with my predecessor in answering these questions. There are no major policy implications in terms of change of policy, because the Minister of Health policy framework spells out embracing technology to improve efficiency And also the reproductive health policy for Kenya embraces use of technology and capacity building. We also do have task shifting policing guideline that again embraces that. Perhaps the only area to strengthen is the community midwifery policing guideline, just to ensure that again, this is defaulted to the lowest level. Otherwise, it's still an impressive approach in terms of the policy direction. Thank you.
Thank you, Narcis. I think some of the chats, and Priscilla, thank you for some of them. You were responding to them, and I can see that some interaction, and some of the responses are quite elaborative also from that end. We have the last question, which I will project it to. I will start with Dr. Matiang'i and any other panelist who can quickly give inputs on the same. Do we see this project embraced by MNCH priority counties? What should be done to institutionalize this intervention? Dr. Matiang'i, please, you can initiate.
Rukia, I'll talk on behalf of Dr. Matiang'i.
Okay.
He has left urgently for an important meeting, but the goodwill of our county governments is needed for them to see the need of improving ANC services for the mothers within their counties. And coming from the results we have from these two different counties, those who are coming from priority counties can actually see the benefit that would be there for their own mothers. We have seen partnerships with UNFPA, like was mentioned. We have managed to purchase more of this equipment to 2 more counties for 4 facilities, and we expect to see more of partners who are in the MNCH front coming up to support such kind of interventions and innovations. Secondly, counties should be committed to building the capacity of their healthcare providers, and in this sense, building the capacity of midwives so that they're able to provide this basic obstetric ultrasound screening, and that will definitely improve the way the mothers get their services, the referral systems, and so forth. Thirdly is having NHIF reimburse for a service that is provided by a midwife. So for example, for NHIF, it's something that we had in conversations with, and we'll continue the conversations with, to see it being fruitful to a point that now counties can actually get reimbursements from NHIF for that. Thank you.
Thank you, Priscilla. I think this question still goes back to you. I can see a few responses that you have made, but what were the most prevalent pregnancy risk factors that you had experienced?
Yes, that had been initially tackled by Dr. Matiang'i, but some of those were, for example, we had low-lying placentas being reported. We had decreasing heart rates being reported, and those were the people that were actually being referred to other health facilities. At some point, about 6 months into the project, we had about 35 cases of risks that had been reported and referred.
Thank you very much. We have also a question from Karthik, who's requesting from the panelists. I think the Priscilla, you will take it up because Matiang'i is not available. Advanced apologies if this has been addressed before, but between training and supportive supervision, that is one, consumer awareness around ANC, and finally the actual product and its technical attributes and sustainable business model. Is it possible to indicate which of the following were most critical to the successful outcome of this particular project? So which one among the 3 will have been, or is it all factors that he had mentioned contributed to the success of the project?
Mm-hmm. Yes, that had also been tackled, but we had said that this cannot be a one factor success. It was many factors that led to the success. Something that had not been included was the involvement of the community health workers who helped to sensitize the community about the service and its benefits. And after the 2 sensitizations that we did months apart, we saw an increase in the uptake of the ultrasound screening. As we were going to close out, that was in December last year, we also had another community sensitization in the 2 counties, and we saw the interest of the community health workers in also helping the mothers to come to the facilities. And we are going to continue to engage these community health workers in the future so that they can continue to encourage the mothers to go to the facilities.
Thank you, Priscilla. We have also one participant who wanted to know if these services will be made free of charge. I think you mentioned that there is an opportunity to liaise with NHIF to provide these services for free, which is some of the areas that the project can actually focus on. The other question comes from Alina. Can the clinical indicators and KPIs be shared for this pilot, please? And can the business case also be shared? That is from Alina.
Also
to you, Priscilla.
Yes, okay. Okay, that is noted, yes. Please provide your email address and contacts.
That's to Alina. I think you can liaise with Priscilla to get the information as required. I think we've managed to go through most of the questions. Some of them, as you mentioned, Priscilla, were answered under the presentation that was done by Dr. Matiangi. Maybe one more that I will wish you to respond to. After midwives were trained, ultrasonography, of course on ultrasonography, were they, I guess he meant to ask, were they followed up to the end of the pregnancy, especially under the supervision of the midwives, or is it just a period of ultrasonography that you had contact with the mothers?
Great. So majority of these mothers who were screened from the facilities that they go for ANC. I remember sometime last year when we were doing an operational research, we were calling back the mothers to have a focus group discussion on the experience on the ultrasound. And about 15 mothers were all holding babies because that is normally their ANC clinic. Very few of the mothers had to travel far. You remember one of our objectives was bringing the service closer to the mother. Very few of them had to travel quite a distance to where the ultrasound was. And most of these mothers have been seen from the first ANC to the last ANC clinic up to postnatal period. I would like to point out, I like giving an example of Namanga Health Center. Between Namanga Health Center and Kajiado County Referral Hospital, you have to travel about 90 kilometers in between there. And the only public facility that has an ultrasound was the Kajiado Referral Hospital, public. Only one facility that is a private facility in Namanga provides the ultrasound at about 1,500 shillings. So you find that mothers have to travel such a long distance to get to an ultrasound. But those mothers are those that are usually seen at Namanga Health Center. Once we brought this ultrasound to Namanga Health Center, now we found that most of their mothers were satisfied and reduced their travel out to go and receive the ultrasound screening.
Thank you, Priscilla. And maybe one final question to you as we, I think, conclude, because we have a few minutes to end of our session. This is from Professor Malin. She's asking how many women, of the women were less than 24 weeks? That is question one. And we have the second one, what are the quality of care mechanism built into the service? And are the women willing to pay representative of the population or skewed towards the more healthy? So those are the questions from Professor Malin.
I could clarify or check on the number of mothers below, those who are screened below 24 weeks. But I could mention about the last question. Please repeat the middle one. But the last question about was it skewed to mothers who are more wealthy? The answer was more wealthy. It's a yes and a no question, because we still found mothers who are not socially economically able saving up money for a period of time to pay for this ultrasound. Theirs was a comparison of how much an ultrasound will normally cost, which is about give or take 1,000 to about even 2,500 in some of the facilities surrounding the business units we had. And when they compared that, they would rather save up money to get this the 500 shillings ultrasound. For those who are more economically empowered, that would come as a no-brainer because it was now even more affordable. There's something else that Rukia, you mentioned as a second answer.
And two was, what are the quality of care mechanisms?
What was? Yes, the quality of care mechanisms that we ensured was one that one of the things that we did was ensuring that we had the sonographers who are the experts in this area being our trainers, and after that being the people who supervise these midwives for about 3 months. If, for example, a midwife had a query on what they were seeing and they were not sure about that, then the sonographer would be available to give guidance and help during that time. And therefore, we had quality reports being given to our mothers.
Thank you very much, Priscilla. I think we have very few minutes left before our session is over. In case there is probably from the panelists, in case there's any critical points that you would like to relay to the participants and also to everyone, feel free to do so before we can go into our closing remarks.
Okay, Rukia, can I go ahead?
Yes, please do.
Okay, thank you. It was a great presentation indeed. One of the things that I think so far have come out as far as the issues of training midwives on point of care is we need to have a standardized training, in the sense that we need to be able to have a midwife in Kilifi performing the same point of care as a midwife in Kisii or in another place. And this calls for a lot of multi-sectoral collaborative approach, like the way AMREF got involvement with the Society of Radiographers, AMREF, Nursing Council, and by so doing, realize at the end of the day that we're able to reach out to the midwives in a much more better way, in a well-equipped version. And I think that will be an idea that we need to approach. And on the issue of how, or whether how this can be absorbed in the mainstreamed in the international health policies, I think one of the things that I would like call upon most of the people sitting health policy decision making to consider having evidence-based approach. Like, for example, the results which are being projected from this pilot project, that yes, we're able to improve maternal health services through having the frontliners, who are the midwives, being able to perform point of care ultrasound, which is like an added tool for them to triage their patients much better. So going forward, we look forward to having evidence-based practice in terms of implementation of policies. Thank you.
Thank you very much, Jackson, for your inputs. And I think that cannot be emphasized more. Because we have very few minutes, then I will say that this was a great opportunity for also all of us, including myself, who's really interested in maternal health, gaining such a wonderful insight from the project. And I believe most of the participants also have felt that this was a great project that needs to be emulated. In the interest of time, I'll focus on some of the key things that need our attention. That is task shifting. Task shifting is key for us all. We have realized for us to achieve positive health outcomes at the primary health level, healthcare level, we need to focus our energies on providing solutions such as utilizing such midwives who are already retired probably, and community health workers who are in communication with our community members on a daily basis. The other issues that were raised are the policy issues. Collaborating with the relevant stakeholders and multisectoral approach is very key. We have also the issues of quality assurance that has been mentioned. The quality of services provided by the midwives need to, of course, be supervised and of course share the previous and the current learnings with the necessary persons, and especially the beneficiaries themselves. We also talked about the demotivation of the community health workers because they are not remunerated, and these are opportunities that can give them the motivation they actually require. Earning from the services that they're providing will keep them motivated, because at the end of the day they will have a few coins that they will go home with, and that will be the best approach to ensuring that everybody in the workforce in the entire community health system is working together comfortably, fully trained, earning something at the end of the day, and delivering the same outcomes that we desire for all our mothers and the community at large. It's not only about the women, it's also about the child, it's also about the elderly, it's also about other cohorts, the youth and the young people. So definitely what we will envisage to see is that every aspect is addressed and the potentially sustainable solutions have been adopted across the globe. So having said that, this particular project that I had mentioned earlier, we are also working alongside Philips Foundation. They have fully funded that particular project. And we're using one of their expertise, that is the Philips CLC kits for their, they had made for the rural setting to provide the necessary skills at the lower level of the community health workers. So they were able to provide a bag which had various kits, the blood pressure monitoring kit, the charm, which is used for respiration monitoring for young children to track pneumonia. We have the MUAC tape, we have the scale for growth monitoring, and these are the basic skills that community health workers actually provide at the lower level. So you can imagine if we couple this with the opportunity of the midwives being their core service providers and at an enhanced level, which is also providing the ultrasound services, which is lacking in the current project, can be a very good opportunity for us to deliver more services at the facilities. And we also look at the sustainability part of it, whereby the model is more of a social entrepreneur models than just the grant models. So I would like to thank Philips Foundation for doing this extraordinary services at the grassroots, and they continue supporting our primary health care and access to care that they're actually very strong in. And well done, Priscilla and team, for the concept that you have developed and actually actualized it, and you're today giving us the experience you've had. We also like to thank the National Council of Kenya and the Ministry of Health for giving the support required where necessary. We also like to thank the Radiographers Society for supporting on the training and the policy issues and clearing the way for the project to be executed. And the participants also, thank you very much for your contribution, and thank you very much for participating, finding time to be here with us to listen to this great initiative. I think at this point, I feel I will give the opportunity to the panelists, if there is anything you want to add on that. If none, then we can allow our participants and also the panelists to leave the meeting.
Ms. Rukia, just one thing that I think we need to think about. As we move forward, we need to have a wider stakeholders consensus to include Division of Reproductive and Maternal Health Services, Ministry of Health Legal Department for advice. Remember, we are dealing with cross-cadre issues, and as much as we have the guidelines, we also have a lot of litigation. So going forward, kindly let us think about incorporating everyone for buying in, so that as our midwives provide this very essential service, then they are also safe wherever they are. I know we have incorporated this into our scope of practice for BSM, and I think it's going to go a long way in helping both the midwife and the community at large. So as we move forward, let us sort a wider stakeholders consensus. Thank you very much.
Thank you, Ms. Grace. That is quite important for us to take note of, and for us to have everybody's blessings in the project to avoid any hitches in the process of execution. Any other person who will wish to comment before we close?
From the Minister of Health is to thank all the participants and the panelists, and to thank the team for work well done. This is a move towards the right direction. Thank you very much.
Thank you very much, Ms. Ruth. We appreciate your presence here today. Anybody else from the panelists?
Thank you. On behalf of...
Go ahead.
On behalf of AMREF International University and AMREF Health Africa, we are grateful that you came and took part in this very engaging webinar. We hope to do better things, bigger things, and we will surely invite you all. Thank you so much.
Thank you, Priscilla. Mago, you had something to say?
Yeah, very little. I'm just very grateful for this meeting, and I think this is what it comes down to: sharing our experiences, trying to find ways to deliver healthcare to the underserved. And I think we can all be very happy about the results, the learnings, and I think we have to take it from here. And thanks for moderating this in a wonderful way, Rukia.
Thank you very much, Mago. Just for Priscilla, quite a number of requests that you share with them, the indicators, the KPIs, and some of the learnings. There is Majoline, Alina, and Enya Seguin. She had all requested that you share with them. They have in the question and answer, you will find the emails. And I hope we've answered all the questions from our participants here today. Then if not, please feel free to reach out to Dr. Matiangi and Priscilla for any response that you will require, either through email or through even phone calls, or even reaching out to them. Having said that, I think it was a wonderful exposure for myself and also for learning mechanism. I will be also giving lessons learned on a project that we are conducting in Marsabit County for maternal health, and of course the potential for scale up for discussions. Once again, I say thank you for the opportunity. I will ask that the session is actually now over, that you will be able to leave at your own pleasure.
Thanks, bye.
Bye-bye. I think we'll be left behind with Priscilla and Anthony, if I'm not wrong. Yeah.
Thanks. God bless you all.
Thank you. Thank you very much for participating, everyone. We appreciate.
Thank you.